I'd like to introduce the first speaker, who is going to tell us about the current epidemiology of invasive fungal infections. It's Nina Khanna from Basel. Thank you.
Thank you so much. I would like to thank the organizers giving the opportunity to present here today. So I'm going to talk about the current epidemiology of invasive fungal infections. So these are my disclosures. So why is it important at all to know the epidemiology of invasive fungal infections? It's because there is a very high burden of serious fungal infections, which has been shown by the global action of funds by fungal infection. As you can see, for example, in HIV, there are around 1.2 million AIDS-associated deaths a year, and of these are 50% caused by fungal deaths, such as aspergillosis, histoplasmosis, cryptococcosis, and pneumocystis jirovecii pneumonia. Also, for tuberculosis, there are around 5 million new cases a year, and the sequelae of those diseases are, in 1/4 of cases, they have chronic pulmonary aspergillosis. And for cancer and fungal infections, as you all know, they are always at high risk for fungal infections due to major surgery, chemotherapy, radiotherapy, and particularly leukemia patients, they have fatal fungal infections in 130,000, and lung cancer have 32,000. So the case fatality is per species quite different, but the case fatality ratio of above 20% has been documented for Candida, Aspergillus, Histoplasma capsulatum, and Zygomyces, which is up to 30%, despite very different incidences. So, however, it is very, very difficult to have an accurate estimation of the true burden of invasive fungal infections. The reason for that is that there is no formal, systematic, or mandatory surveillance program specific to fungal infections in almost all countries. There is a variation in definitions, and there is a limitation inherent to available case-finding methodologies, such as diagnosing billing codes, then microbiology records, they only identify a fraction of infections, and so on. And the availability of diagnostic tests are not throughout available in all countries and in all hospitals. And also the difficulties in diagnosis, as everyone knows, surgery, radiology, biopsies are not performed in every hospital the same way. And even more, anti-fungal prophylaxis nowadays reduces the sensitivity of diagnostic tests. So I would like to show you a quite new study which tried to estimate the epidemiology and clinical features of invasive fungal infections in a US healthcare network. And they used a novel case-finding methodology. So they went back to their data warehouse, where they have more than 1 million patients per year, and included records from 2006 to 2015. And as you can see, they used laboratory, microbiology, pathology, radiology, ICD codes, immune suppressive medication, the antifungal medications. So they included a lot of variables, and then they had a lot of data elements, excluded the superficial mycosis, non-invasive mycosis, wound cultures, and candiduria. And at the end, they were left with 3,600 IFI episodes, and the final cohort you can see here was 3,300 IFI episodes. So the results of that study was that they had a mean incidence of 27.2 cases per 100,000 patients per year. And here you can also see the incidence per species. For example, the highest incidents were caused by Candida, and at the second was, because it's an American study, dimorphic fungi, which would look very different here in Europe. And then at the third place was Aspergillus, with around 2 to 3 cases per 100,000 patients. And at the very low level are the zygomyces. Overall, they saw a 1% annual increase in incidence over the study period, and the age group was in median 55 years. 13% were children, and risk groups were mainly immune-compromised patients, cancer patients, and particularly 1/5, so 20%, had corticosteroids before, and lymphopenia was also associated with invasive fungal infections in 22%. There are recent data from France and the United Kingdom which show comparable population-based estimates of 20 or 14 per 100,000 patients. So what do we know about current data on incidence of invasive aspergillosis? Here I would like to show you a recent study where they included data from 40 different countries, and they found a mean rate of 4.1 per 100,000 from 40 countries, which is actually quite similar to the study which I showed you with this 4.1, and approximately 10% were in AML patients, 6 to 10% in stem cell transplant patients, and approximately 4 to 6% in solid organ transplant recipients. So how are the risk groups and species distribution? And the species distribution really varies according to clinical service and underlying condition, which has been published in this review. And what you can see is that Candida, invasive Candida infections, they occur in practically all clinical services, such as medical services, immune-compromised services, but also in surgical services. However, for Cryptococcus and endemic fungi, there is mainly they affect HIV patients, and Aspergillus and zygomycosis mainly affect hematological patients with malignancies or stem cell transplant recipients or solid organ transplant recipients. So I would like to show you some recent data from Switzerland. And we have actually a Swiss transplant cohort, which is a prospective, multi-center, long-term open cohort for scientific research and reporting of all stem cell transplant recipients and solid organ recipients transplanted in Switzerland. The patients are enrolled prospectively since 2008, and it is continuously funded. So first of all, I would like to show you the epidemiology of invasive aspergillosis in solid organ transplant recipients over a 5-year period from 2009 to 2014. And what you can see, we had an incidence of 2.4% in this cohort, which were 70 patients of 2,868 included, solid organ transplant recipients. And as you can see, mainly it affected heart transplant recipients and also lung transplant recipients. The risk factor for invasive aspergillosis in that study was reoperation, as you can see here, with an odds ratio of 6, but also rejection, bacterial infection, CMV infection, and respiratory viral infection was associated with invasive aspergillosis. And the mortality compared to a matched control solid organ transplant recipients was higher if the patient had experienced an invasive aspergillosis. As you can see here, up to 25% of mortality compared to 10% mortality over 5 years. And this was practically seen mainly in liver transplant recipients, probably due to the late diagnosis, and much lower in the lung transplant recipients. So similarly, we did the same study in stem cell transplant recipients, also over 5 years. And what you can see here, we had 480 patients included over 5 years with a median follow-up of 1.5 years. And the 1-year incidence rate for invasive candidiasis was 2%. And for all invasive mold infections, 5.6%. There was a little bit more invasive aspergillosis with 3.5% and 2.1 non-aspergillus. And what you can see also is that the candida infections occurred early after transplantation, whereas the mold infections occurred late, which is well known. What we also saw is a high 6-week mortality, particularly for invasive mold diseases, but not for invasive candidiasis, which was 20%, and 54% for probable and proven invasive mold diseases. However, there was no difference between invasive aspergillosis and other invasive mold diseases, including zygomycosis. So risk factors for mortality after the diagnosis of invasive fungal disease was the stem cell source, so bone marrow transplantation was associated with a higher mortality. The time after stem cell transplantation plus steroids and CMV reactivation was highly associated with mortality, which actually shows that the patients who were suffering from immense immune suppression due to graft versus host were at risk for a higher mortality. So now I would like to switch to mucormycosis, and what is known from the literature, there is 1 to 2 per 100,000 to 1 million patient. There has been a recent study looking at the clinical epidemiology of mucormycosis, and they used the data source and did a review over the Ovid Medline and Embase from January 2000 to 2017, and they included 851 patients from 600 articles. And there were about a third from Europe, a third from Asia, and a third from North and South America. And underlying conditions was mainly diabetes, which was more common in Asian and African countries as in Western countries, and the hematological malignancies, which were more common in the Western country. Importantly, what I have to show is that 51% did not receive any form of immune suppressive therapy. So they also looked at the association between various underlying conditions and disease manifestations. And particularly for diabetes, they mainly affect renal-orbital cerebral mucormycosis, and solid organ transplantation. They have mainly an affection of the lung and disseminated mucormycosis. Hematological malignancies, mainly disseminated, and neutropenic patients have pulmonary mucormycosis. And what we could imagine is that major and minor trauma are associated with cutaneous mucormycosis. So within the next few minutes, I would like to give some overview about the incidence of breakthrough invasive fungal infections, as this is currently in the era of anti-mold active treatment a big problem. So first of all, one of the major issues is the difficult case definition. And by a recent study of Oliver Cornely, you can see that they tried to defer the different treatment responses to invasive fungal infections. And what is important is that breakthrough IFI is defined as any IFI occurring during exposure of an antifungal drug. And it is always difficult in every study, what about fungi which are outside of the spectrum of activity of an antifungal? So for example, fluconazole and the occurrence of a mold infections. And even more, another problem is the diagnostic accuracy. So here you can see many different CT scans, and everyone would think that this is an invasive aspergillosis, but at the end, when you look at the diagnosis, there are many other infections which can cause these kind of lesions in the lung. So importantly, only probable and proven IFI should be included. And in the recent review by Leonakis, they put together all the proven and probable breakthrough IMI in adult patients with hematological malignancies or stem cell transplantation receiving mold-active antifungals for primary or secondary prophylaxis, which is really a very nice overview. And I tried to put one of the tables together. And what you can see here is that there are a lot of data for posaconazole prophylaxis, 11 studies, including 2,200 patients, whereas there are big differences. Of course, for isovuconazole, there are not so many data. But what you can see is that the frequency of breakthrough invasive mold infections is between 3.3 and 6.4%, and it varies a bit between the different fungal drugs. What we also could see in our study, which we published from the Swiss transplant cohort, is that we can see a shift to other than Aspergillus fumigatus molds in breakthrough invasive fungal diseases, as you can see here. So patients who have a primary invasive fungal disease, they mainly suffer from Aspergillus fumigatus, either diagnosed by microbiology or by galactomannan, whereas there is afterwards in breakthrough IFI a shift towards Aspergillus non-fumigatus, as well as also other filamentous molds and mucorales are more prevalent in the breakthrough IFI. So I would like to lose some words on influenza-associated aspergillosis. So here I would like to give you an overview about the epidemiology of severe influenza. And there has been a Belgian study. They included around 500,000 flu-like symptoms, where around 300,000 had a confirmed diagnosis. And here you can see the severity of these influenza patients. And around 15% over this time period had a severe course, whereas 6% was the mortality overall. And as you can see here also, the ICU admission varied between 7% and 11%. So what are common influenza complications? Of course, first priority is bacterial co-infections, ranging from 2 to 65%, then myocardial infections, myocardial infarction, and also invasive aspergillosis, which has been reported in a Canadian study of 7% and in the Netherlands of 19%. So what is now the epidemiology and their risk factors? So the epidemiology varies between 7 and 23%. There are approximately a third are immune-compromised patients, and the occurrence is independent of the type of influenza, so A or B, and it's also independent of the season, and importantly, 19% have no comorbidities. What is also important that corticosteroids have been associated with a higher risk of influenza-associated aspergillosis. There is still a difficulty in the diagnostic criteria for influenza-associated aspergillosis, as the ERTC criteria do not match, and they have been new modified definitions, which I don't want to highlight here. But based on that, I think what previous studies showed is that the morbidity and outcome of this influenza-associated aspergillosis are quite poor, with mechanic ventilation up to 90%, ECMO use, as well as also a mortality between 33 and 70%. Last but not least, I would like to show one slide on azole-resistance. As everyone knows, in the Netherlands, there has been an incidence of 5.3%. In the USA, in recent study, 1.5%. And we just have recent data from Switzerland, currently unpublished, showing that we also have around 1% of incidence of resistance, azole resistance. So I would like to summarize. It is very difficult to have a true incidence of invasive fungal infection because of the limitation of reporting and the difficulties in the case definition. However, invasive mycosis remain a major cause of morbidity and mortality in several high-risk patients. And the aspergillus still are the major etiologic agent for invasive mold infections, and the incidence and clinical presentation, they differ within the different risk groups, as I could show you. And I think also maybe we will see instead of influenza-associated Aspergillus infections, now also influenza-associated corona infections, corona-associated Aspergillus infections. So I think this story is still evolving, and the incidence and awareness of mucorales infections has increased also in non-immune compromised patients. Thank you very much.